discussion, Bridging Borders, Psychiatry Teaching and Training from Kashmir to Kanyakumari. The moderator for the session is Dr. Vinay HR. I would like to welcome Dr. Vinay HR on the stage. Thank you, sir. The speakers for the session are Dr. Survi Patra, Dr. Adnan Kadiani, Dr. Virupaksha HS, Dr. Ram Kumar GS, Dr. Ajay Kumar, Dr. Harshit Hemant Salian, Dr. Snehil Gupta. Dr. Vinay HR is the Associate Professor and in charge Head of Psychiatry, Faculty of Medical and Allied Health Sciences, Adi Chunchanagari, Institute of Medical Sciences. He is interested in psychiatry teaching. I request Dr. Vinay HR to introduce the speakers.
Yep.
Yes.
So let me start with a disclaimer that for this panel discussion, the experts are both on the dais and off the dais, and it involved a convenient sampling rather, because we had to search for state representation and also in terms of designation involving professor, associate, assistant. And other disclaimer is that what they're going to share is some of the ground realities and also share some of the insights about what they're undertaken in terms of UG and PG teaching. So others can actually either pose questions or also add as comments. So we have in our panelists, so Dr. Survi Patra, Madam is a professor at AIMS Bhubaneswar, Orissa. And we have Dr. Ajay Kumar, who is an associate professor at AIMS Raipur. And we have Dr. Virupaksha HS, professor and head MS Ramaya Medical College, representing Karnataka. We have Dr. Ram Kumar GS, associate professor at Government Medical College, Idukki, Kerala. We have Dr. Harshit, who is an assistant professor at AIMS Jammu. We have Dr. Snehil Gupta, associate professor, AIMS Bhopal. And lastly, Dr. Adnan, who is an assistant professor, TNMC, Mumbai. Right. So what we're going to do is, so each one of them will have a question based on what they've chosen as they would like to share insights regarding. So first of all, we'll start with Dr. Ram Kumar. He's working in a government setup. So how is that the small group teaching and clinical postings with regard to undergraduates are handled at your place?
Okay, thank you, Vinay. Before I begin, I should say that this has been a very excellent conference. And I had, as far as my college is concerned, undergraduate students are arriving in my department soon. So I thought I should kind of upskill myself in terms of the teaching learning methods. Somebody earlier during this conference had said whether we are automatically equipped to be a teacher just by finishing our post-graduation. I realized that doesn't happen. In fact, I got the opportunity to attend the advanced program by the NMC Nodal Center, which also I was familiarized with the latest concepts. One among them is the small group teaching, which is the topic given to me. It is also a new concept, how to conceptualize it, how to implement it. There's a lot of confusion. If you look at the scenario in my state, the automatic response regarding the small group would be the space constraint. Some colleges, the established colleges like in Trivandrum or Calicut, would have adequate space, but new colleges like mine do not have that. But Trivandrum and Calicut will have 250 students. I have around 100. So how to go about arranging the space for these small groups? The discussion has been that we should conduct a kind of a space audit, whatever facilities we have. So that has been what we have been trying to do. Then in terms of the methodology, many are not sure how to go about. Then the staff shortage, which could be a constraint. Now there has been a discussion that we need not have subject experts to conduct small group. No, we need to have what is called as a process expert, how to engage the students in small groups. So that can be a JR or a third year resident and all those things. So these are the initial thoughts about small group. Whether technology will facilitate is also one aspect. Like I got the opportunity to do a flipped classroom in my college as part of the ACME project. So the discussion which would happen based on the flipping would be a small group method. So I think it's an evolving area. I'm not sure how others are doing it. These are my thoughts on that aspect. Thank you.
Yeah, thank you, Dr. Kumar. So that's a actual thing that, yeah, for the small group teaching, people think that, okay, we'll have to have a separate classrooms for that, each faculty engaging in, but that's one other way that we can think of. Okay, right. Coming to the PG education here, so Dr. Survi Patra, madam, so are PGs getting involved in teaching the UGs? If so, how it is provisioned in terms of teaching, learning, and also assessment part?
So belonging to AIMS Bhubaneswar, we have like for UG students certain designated classes. So in addition to the theories, there are practicals also. Now what we are doing at our center is like we are particularly focusing on clinical skill training. So particularly during internship is where we use we train the UGs to train the interns particularly about the history taking skills and conducting the mental status examination also. So once an intern enters particularly and during this clinical posting, all these things are taken care of in terms of clinical skill teaching. And when we are talking of the UG posting in the ward as well as OPD of psychiatry, many a times these are being taught and demonstrated by the SRs and as a JR in addition to the what SR is doing. So it's a team wherein you have like titrated approach. Sometimes the team goes from downwards to upwards or upwards to downwards with varying involvement of the faculty at different level. So what we could find out that when we conducted OSCEs for interns, like our institute conducts the exit level OSCE for all the interns. So at exit level we could see or we could take help of the JRs in terms of role playing as patients. So they also learned like in terms of how do they play the part of a patient and how these fine skills of assessment is being conducted. So after that it was like more of a backward to like a forward approach wherein the training of clinical skills percolated towards the routine ward teaching. From the assessment backwards to the ward teaching of the let's say third semester UGT students. This is in terms of you can say the clinical skill teaching which is involved. Now what we have started is like teaching the undergraduates, teaching the postgraduates with the skills of teaching. So we are conducting micro skill teaching for the postgraduates in psychiatry in our department. So what I am personally going to take this forward is like one topic for undergraduates. These PGs would be asked to conduct in terms of small sessions under monitoring with the faculty. So what happens that they learn that particular content, they learn how to train the UGs and monitoring is going on with the faculty with formal teaching of the training skills of teaching. So this is how we are doing and I think it's a long way to go and with each step we are learning and I'm growing as a faculty also. Yeah. I would like to take any suggestion and comments from the house.
Maybe we'll have it in this thing slide, ma'am. Yesterday, Dr. Priya Sridharan was also mentioning about assessment being a part of in the curriculum, whether this is being assessed, ma'am, because pedagogy is one thing which pre and paraclinical subjects PG programs have it in their curriculum as per the NMC, but
yeah, we particularly do not have an aspect like as a competency it's being assessed, but as it was found out and reported by the postgraduate students themselves that they would want to learn this as a competency. So after that, we started taking these sessions on a workshop mode and during off time from the wards and OPDs, no? Maybe from 4 to 5 on one day. That is how we are doing.
Right, ma'am. Thank you, ma'am. So there were take-home messages there. One thing is that directly or indirectly, their PGs can be getting involved in the teaching of UGs, and also micro-teaching is one teaching learning session that you can adopt for their teaching skills. Moving ahead, this question is to Dr. Snehil Gupta. How are the learning needs of internship addressed? So we have competencies mentioned for the undergraduation, while broadly the goals are mentioned for the interns with regard to psychiatry.
So interns are a unique batch in terms of two things. First, they have passed their final exam, so they are exposed to now clinical situations. So this is the time they are also mentally prepared that they have to serve the patients. So this seems to be an appropriate time where we can actually teach them psychiatry core skills, including the soft skills. The problem is that now they are more towards the PG entrance also, and considering the marks that psychiatry carries, their interest may not be that much. So how we are kind of evolving with interns, teaching or engaging them, first is when they come to us, I personally take an orientation session. I ask them what are their learning needs. They have learned theory, but what do they think as a professional they want to learn in psychiatry, including AdCom, including psychiatry research. From there some ideas get generated, and I try to channelize those ideas under various aspects. For say someone say I want to learn psychotherapy. So I give them options ki you can sit with psychologists, two days you can sit, both child and adult psychologists, and learn the art. Definitely you can't learn complete psychotherapy, but get an orientation. Likewise, when they want to say, they say I want to learn ECT. So that's how we engage them. But it's not something like that we tell you learn these things. What they have told, their needs that they have come up with, try to engage those with them. To involve them in the learning, we have a daily log or attendance kind of thing where we have mentioned cases observed, cases performed. So if they have done any workup in the OPD, they'll mark it, and the concerned person with whom they have sit, so he'll sign. In ward, what we are doing, the very first day when they are coming to the psychiatry, we tell them, we attach them with one patient, and we ask them to, you have to follow this patient for next 2 weeks under supervision of a JR. So that's how the JR intern involvement will be there. And again, during their exit, we do a kind of informal kind of viva. So we ask, with that particular patient, what did you learn? What was the diagnosis? So those kind of things we are doing. I have involved SRs. So we have 2 units. So SRs are earmarked for this particular batch. This SR would take their training forward, and in this particular, this SR. Including for everything, if they want to take leave or they have other issues, SR is the nodal person. That's how SR also comes into the picture. That's how we are doing. But these are all positive things that I am telling. What are the negative aspects? If you somewhere you are not available, so that orientation thing may not be practiced. And the very first thing, if not done properly, the rest of the thing would fall apart. Secondly, even we try in every round we allow them to present their cases. But if you are not there, round is cut short because of some meeting, some administrative responsibility, personal issues. Again, the learnings get diminished. So it's a teamwork, I would say, involving SRs in particular. Particularly, I face difficulty involving JRs in teaching because our JRs are already overburdened. If a department has lesser number of PGs, so it won't be their priority. So that is my say on it.
Yeah, thank you. So you did make a mention that the interns, apart from seeing the cases as and when it comes, so there are felt needs which are addressed, and also kind of informal exit viva that you do. Thank you. So when it comes to PGs, so internal assessment is something which is not so, what I can say, popular or made mandatory. So in this regard, what are the strategies that you adopt for the PG program, internal assessment, Dr. Ajay Kumar?
one of the, AIMS Raipur is one of the initial six AIMS which has been, sanctioned by the ministry. And when I joined, then there was just PG courses started, and much of the, PG assessment and the training experience comes from my previous trainings. So I realized that some strategies should be developed to assess them and to objectify their learning and their training and their all behavior aspect, and some mechanism has to be developed, and much of the information comes from this continuous association with the medical education of various platform. ITOP is one of it, and my NTTC training, for example. So we develop a mechanism like we do every 6 months batch is there. Every 6 months there are PGs. So we do a assessment every 6 months. That is the theory and practical assessment that we get a objective marks for that. Okay, and then we have 6 month multiple assessment. For example, we take opinion from the nursing staff, from the other PGs, colleagues, peer from the, and every faculty marks them independently, how their punctuality was, their discipline, what everything. So there is a score sheet, there is a marks for it, 0 to 10. You can and then we collect all these datas. And then there is a direct observation mechanism. For example, the student posted in ECT and neuromodulation. So some of the direct observation will be there, whether they are following the protocol. And we have developed this. For example, I am trying to see the neuromodulation. Then we develop, okay, this 10 competency, at least you should be having this in 1.5 month of posting. So whether you have developed this, whether the ECT has begun properly, whether the MSc has taken for the proper. So direct observation mechanism there. Some skills we have developed for it or adapted from the this thing. So the idea is that to gather all the informations, okay, and enter into an Excel sheet and develop an individual graph. So every student has a graph. Okay, how much they are scoring in the theory, how much they are scoring in the practical, how much they are scoring in the discipline, how much they are scoring in the routine clinical activities. So so that trajectory will be there. Slowly every year they develop. And we have this every 6 months try to have this officially program of feedback. Okay, we show them that those graph on the screen and show them this is how you are more better in the clinical practice, but theory is lagging. So that's how the visible impact will be there on the postgraduates. Okay, these are the areas you're lacking, but you're doing well in the other areas. So this kind of practice, although it's require lots of hard work, because you have to collect all data, you take average of all the marks. So for example, there are 6 faculties, so I have to take average, and some marks will be there. So there one graph will be there. So so that we can show, and that what we have practiced, that we try to make a at the end of the final exam, when the student goes for final exam, we even produce a report of the student performance. Okay, this is the 3 years performance of the student, and we'll put it in front of the external examiner. Okay, so you can have a ease of decision making or something like that. And surprisingly, now the 10 years is over to the department, and now the many pages has passed through. And so those trajectory we have know that, okay, this, if trajectory is there, this graph means this student will be having this kind of a fate. So that is quite consistent. So this is very helpful to make such kind of assessment. That is the experience till now.
Yeah, thank you. So you did make a mention of multi-source feedback, directly observed procedural skills. Right. So as far as our institute is concerned, so we have institutional level internal assessment in theory and department level clinical assessment. Apart from that, quarterly internal assessment with the feedback, which we refer to as formative assessment. Right. Moving ahead. So in undergraduation, we have newly introduced electives. So in this regard, many colleges have offered electives in psychiatry as well. So this question is to Dr. Adnan. So are electives offered to UGs in psychiatry at your place? So if so, if you can just give details.
Thank you, sir. Sir, I barely represent my institute, much less the city and definitely not the state. But what we do in our, this is, so electives have been going on since the last 2 years. We were deciding on what do we do as an elective. And one of the biggest ideas we thought was, let's do soft skills first. So because soft skills is already there, people are supposed to learn and nobody is really teaching it, is what we understood from the students. There was this big debate from our students on their festival that nobody is teaching us soft skills even though CBME mein hai. So we decided to use that as an elective. We made a teaching learning program where we made it interactive. We had games. There's a game called Crossing the River which we had in our department to teach them team building. Then we told them to go interview 2 leaders and ask them questions on leadership traits to come back and discuss with that. So we did a certain clinical posting, elective on soft skills training. There are some goods and bads of that as well. So the good things were, we were able to do it. We were able to figure out resources and do it. That was because it was just once a year. I think if we had to do it more regularly, I don't think we would have been able to do it. We did it once a year. It was for 15 days. The students with us were from 9 to 4. So after 2, we could spend more time with the students. So that was a good thing. Students really liked it. Some things which were a challenge is because, so some students took it up so we asked them, why did you take it up? A lot of them had good answers. Some students were like, aur kuch nahi mila, so this is what we took, right? We were late in giving. So that also happened. So that were the challenges. Space was a challenge, too many people together in one room. So that's always a particular challenge. But we tried to do something innovative in soft skills. We are trying to do child psychiatry clinical posting also, elective also this year. We'll see how it works. That's on clinical, sir. I would just like to add one more. We recently tried something innovative in a clinical posting in regular psychiatric innovation. So since our department has different sections, there's an LD section, there's an autism section, there's the ward, of course. So we did a treasure hunt on day 1 to get them a little more interested into it. So we had set of questions. So let's say a poem, and I used ChatGTP, by the way, to come up with the clues. So unko diya, and then they figured out the answer of the clues, and that's how the idea of the treasure hunt was. They get familiarized with the different sections of the psychiatry department. They liked it. We'll see if we can do it next year again.
Right, there are some interesting things that you mentioned. Of course, soft skills is one. I mean, there are various other things depending on the resources available at their respective colleges, be it child psychiatry, be it de-addiction. So there are various electives, but that's an opportunity, I believe, right? So when it comes to postgraduate teaching, so even yesterday there was a discussion that psychotherapy whether it is really become a part of training. So is it there at your place, Dr. Virupaksha from MS Ramaya, both in terms of teaching, learning and assessment?
Yeah, I think psychotherapy in general, in most of the private medical colleges, somewhere it is not getting the amount of thirst and importance that we were taught during Nimans, I should say. And I also see that basically as psychiatrists, we are also not giving too much of importance to psychotherapy. Lot of teachers in medical college, we are training them clinical skills, we are training them how to prescribe a medication, we are training them neuromodulation, lot of emphasis on theoretical aspect, but psychotherapy as an art that we were told when we were students is not given much of the importance. And I also feel that that is a generic thing across the medical colleges, that students think that they need not know about psychotherapy. And initially in our medical college also, we tend to just probably replicate what we were told, even though NMC doesn't make it like a mandatory thing. It says that, yeah, students have to do psychotherapy, but there is no mandate like other things. So when we tell the students that you need to do at least 10 cases of psychotherapy, follow psychotherapy notes, probably discuss with each faculty. In our college, we say that each student should have at least one therapy discussion with a particular faculty including the psychologist. And many a times what we have also seen is in some of the other medical colleges that psychotherapy should be done only with psychologists. But I think that the supervision and the discussion should be done with psychiatric consultants also. And there is no, when we also tell our students that you need to prepare a psychotherapy notes and submit it, even though that is not mandatory, they come back and ask, when other colleges are not doing it, why are you making us to do it? Because that is an added effort that needs to be done by the students. There is no marking for psychotherapy. So they feel that they can do away with that. I think that is something that is really worrisome. Probably at the larger level, IPS and NMC should take up psychotherapy, this thing. We are doing it in a very informal way. There is no formal way of this thing. So we discuss, we also discuss amongst ourselves the cases that we give to students. But there is no formal assessment or documentation that is happening because it is not mandated, and students also have some moment of resistance to it.
Right. Thank you for communicating the state of things there. So, of course, since we are discussing ideal things as well, so one of the things is supervised sessions and therapy discussion, and also submission, just like a dissertation submission, psychotherapy case record submission is the assessment form that we can think of. Right. So, we will ask Dr. Harshit, who is from AIMS Jammu. So, what are the challenges? Because the panel includes all the kind of colleges here. So, here the challenges faced by faculty, particularly new medical colleges, in ensuring the UG curriculum is implemented. So, if you can just throw light on that.
Like you said, AIMS Jammu is newly instituted. We do have 5 batches of students, but the issue is not that. The hospital started probably 3 to 4 months back. Till then we were associated with the Government Medical College Jammu. So now if you talk about the challenges in my place, I would say first thing is we have a very harsh weather there. So it's either hot or it's either cold. And unfortunately, psychiatry being pushed as, you can say, one of those peripheral subjects, what the academic committee does is usually they keep the theory classes at 8 a.m. or 4 p.m. to 5 p.m. wala classes. So you will eventually see, I don't know how many of you struggle with this, the attendance, if you, I would say it's around 10 to 15%, but obviously when it comes to the clinical postings, there is a good around 90 to 95% attendance. But theory classes, all of them just vanish, and they have this thing, prep ladder and all those things. Now, none of the students are interested in reading books. They are just interested, PPT banao, sir, hame entrance crack karna hai. That is the, I can say the mentality of the students. I don't know whether it's a reverse Flynn effect or what, but that's what is happening at this moment. The students are not interested in learning it to understand, to apply. It's more to crack the exams. So that is one thing. Other thing is that I'm from a new institute, so resources, we are having only 2 faculty and 2 senior residents. So when the OPD is running, to send one of the SR or the faculty to clinical teaching, again that becomes a bit harrowing at times. One more unique thing what I noticed there was the students, most of them come from Hindi medium schools. So their command of language in English is just at a basic level. But when it comes to communication in psychiatry, we need it a bit more nuanced. And that is where somewhere our institute is also constituted English speaking classes for them. So, because a lot of them come from very poor communities, there are some kids who is the first person to have crossed 12th standard in their village. So, there are different challenges. Again, our curriculum, we are following AIMS Delhi. We have, like I was discussing with you earlier, we are having 100 hours for psychiatry teaching, and I'm scratching my head, how do I take so many classes? But overall, I think AIMS is giving more of impetus on psychiatry. So it is good in a way, but probably if I could, my goal to teaching in UG would be so that they identify what patient requires to be referred to psychiatry.
That's what Dr. Sandeep was also mentioning about. Right, thank you. So that's the state of affairs, because we assume that just because NMC has mandated certain things, so there are a lot of challenges, feasibility issues as well. And when it comes to other colleges other than the AIIMS-like institutions, so it is only the 40 hours that has been recommended for other colleges, which includes 15 hours of lectures, 13 and 17 hours of small group teaching and self-directed learning. Okay. Right. So we have tried to finish it early so that there are some comments and questions from the audience as well. And remember that whatever issues that we discussed here, it's not exhaustive when it comes to UG and PG teaching. So there are a lot of things. And even if we dig deep, so there are issues with each of the things from the other experts as well. So I'll thank you for contributing. So maybe we'll listen to the questions and also the comments from. Yeah. So there is this question: if UG students do not achieve qualifying marks in summative assessment, they request for re-exam. What is your opinion regarding this? I mean, this is in general. Somebody wants to comment about it? Because this is not specific to psychiatry, this thing. So, yeah. So maybe this is one thing. One much ignored aspect of UGCM is doctor-learner experience. That's what a learner-doctor method. How is it implemented at the respective institutions?
By Dr. Bhim Singh. So sir, we are talking in terms of the methods that we are using for teaching or their clinical experience kind of.
In second year, what till now, even now, it's not very clear as to what to do. The idea is to give them a kind of a first-hand experience of being a doctor, but not involved in treatment decisions, but being a doctor. Otherwise, they come and present case and go. They don't act like doctors. So this is wherever I have gone, it is not been implemented properly. Most of the times, it's like tag to teacher. Like what they'll do if they tag to teacher. Teacher after rounds will go to canteen. I mean, what they'll do. So, how it is implemented in your institutes, I was just, or anybody can.
Yeah, because theirs is AIIMS.
AIIMS, so I understand. So anybody, like Dr. Virupaksha or anybody in the audience can.
Yeah, learner-doctor method, as Dr. Bhimsen is part of the panel that contributed towards your curriculum. So, it's a method wherein students beyond the routine class hours, they have to be tagged along with the patients, attend rounds, and also be part of if there is any case presentation or something like that. So what we thought of and tried, at least, if not for implemented to the full extent. So whenever they come for the postings, apart from the clinical postings hours, 3 hours in the morning, so they'll be tagged with one PG who is already assigned to a particular case in the inpatient, maybe 3 or 4 of them for each case, so that they follow it up longitudinally. So at the end of the postings, at least 1 or 2 cases they would have seen together. I mean, a whole of how the management worked, investigations, reports, the challenges that were there in terms of family education. So all those things are covered, and at the end of this thing, so they'll also be knowing about the pharmacology part, so that they kind of correlate with the basic sciences as well. So otherwise it becomes difficult to tell them about, and they also take up the responsibility of talking to the patients as well, though they are supervised. They won't be given the primary responsibility as such of a postgraduate.
I mean, at our institute, what I am trying is to tag them to a bed. So like, let's say there are 30 students posted. So respectively from the first roll number, they'll get tagged to a bed, and they'll be acting like a learner doctor to that patient on the bed. So because everybody is not involved in case taking, 2 or 3 people will be taking case. Otherwise, everybody will be sitting and reading MCQs or doing something else. So they should be standing at that bed, talking to the patient, trying to identify, apart from psychiatry, the illness, try to understand from which background this patient is coming, what is his educational status, social status, affordability, because in private college, most of the students who come, they are from a different world. Our patients seem like alien to them. I mean, they can't imagine that there are people who struggle to afford 100 rupees per day to pay as a bed charge. So this gives a lot of insight to the students to understand patient as a person. So this is what I'm trying, but I'm honest, it's not working. I mean, there are a lot of administrative, logistic issues. So I just wondered if anybody else is trying.
Yeah, sure.
Let the big departments do it first.
Yes.
Yeah, that's what
But
what
then
the
what
approach
you
is.
said is what we have understood, that the clinical posting goes on as is, but maybe 1 hour of that posting, the student goes to the tagged patient and works with the tagged preceptor, and then gets to learn about how a patient is handled from start to finish. The problem is a student may actually see this longitudinal care for maybe 1 or at the most 2 patients, but that is still better than not seeing anything, because humanities element gets covered.
Yeah, that's the idea. I mean, only 1 or 2 patients.
Yes.
That's the idea.
Yes.
So there are other things that they mentioned. For the benefit of MBBS students, can NMC give CBME textbooks which are aligned and integrated for respective subjects throughout India? So this is something which is broader beyond the scope, but at least Indian Psychiatric Society can think of coming up with a multi-staff. With respect to language, observations are different. Most of the students can't speak local language, posing big challenge in training. So one thing you said about English, so
Yeah, I would agree to that when it comes to communication skills, but when you are learning from your textbooks, you are reading from English textbooks, so you will need to have some working knowledge of English, and that is where the students are struggling. So I would say, I also want to combine one more question there. Dr. Ganesh has asked about whether we need regional languages, medical education in regional languages. I'll combine both the questions here, but my point is, I have officially been a wanderer in India.
yeah.
I worked across states. So if I would have had my medical education in a regional language, probably I wouldn't have been able to do it. So I would say yes, English you need for your theory, but I would completely agree to what Dr. Bhimsen says. Wherever you are, you have to learn the local language. If you are in Rome,
Yeah. So the other question is, do you use simulation-based training in your college for the undergraduates? If yes, how?
In our
Panel.
institute, we have a simulation lab, and we are still in the state of inception, wherein the surgery department and anesthesia department, they are using the simulation lab to teach procedures. So that is how it is. But as psychiatry, I think we are not yet at a level wherein we can use simulation. We are still at role play, and we need humans.
Yeah, today we had a paper
And we need
presentation as
language
well.
also.
So
We have a quite advanced simulation lab, but psychiatry, we have never entered the lab, because there is hardly anything to offer. Yes, but we can, there is something, some software which can help students to understand the brain anatomy, like 3D models of brain dissection, that we can use for postgraduates in psychiatry department, but otherwise there is nothing, I mean, right now,
Right
simulation
now,
lab
yeah,
to
we
offer.
can't say.
So all of us are doing is role play and videos.
yeah, there was one morning paper presentation on simulation-based. Maybe Dr. Ganesh is there, I think, right? Yeah. Yes, ma'am. Yes, ma'am.
This thing is not, yeah, it's working now. I think we're mistaken. Simulated patient, we need not be in psychiatry. I know we're all very tech and bot and robots and all, but simulated patient and training them over 1 week, and having resources. We tend to resource on rely on postgraduates and interns, but we can even train people, other, say somebody from the office who we can call at any time and doesn't pass through so when we say simulation in psychiatry, we do use it for eliciting signs and symptoms of depression, for example. Now the PG may act as the patient. So I think we can proudly claim we do use simulation in psychiatry, also in ADCOM sessions all the time. And in psychiatry, when you want to elicit signs and symptoms of, say, stress-related disorders, and there's nobody in the ward, easily or not so easily, with a little effort, we can use personnel, and that is simulation in psychiatry training.
Yeah, maybe because he was the one who presented that.
Oh yeah,
Maybe
sorry.
he'll
Sorry,
provide the
Ganesh.
distinction between the role play and the standardized patient or a simulated patient.
Yeah,
maybe you
hi,
can
I'm
say.
from Dakshin Kannada. So, in as far as my knowledge goes, in Dakshin Kannada, KMC Manipal has a SP bank. So they have budget also to hire professional actors, and they same actors keep coming every year. So, for the, I think in IJPM or somewhere, Dr. Ravindra Monoli and Samir Praharat sir, they had. Published a paper also on that. They have a SP bank. We didn't have a SP bank, but we didn't have the budget for that. So we had to train our junior residents only to be the SPs.
Yeah, so that's what is there. I mean, standardized patients there. So
I have a
Sandeep sir,
comment on
we'll,
this.
because of the
Excuse
time,
me.
yeah.
I'm Dr. Poonam. It's good that if you are doing this kind of a simulation-based training, but aren't we psychiatrists supposed to be trained to even, evade through that and find out that he's acting? So is it like, it is good at a JR level or just good for training, but should we not train them to also recognize the people who are acting?
That's not the task what we are supposed to do.
Yeah.
We are supposed to teach them psychiatry. So the
Yeah.
medium might change
Yeah,
or
there are a
vary.
lot of patients who come with fake depressive symptoms,
Yeah.
fake anxiety. So it is our
malingering-
responsibility to train them in recognize
So-
the fake.
Yeah, exactly, ma'am. So what we would say is like, what is it what you want to intend to train? Is it malingering? Is it factitious disorder? Diagnosis of these disorders? Or you are trying to use or you are trying to involve somebody to demonstrate those things? So like one is diagnosis, one is eliciting the diagnosis. Even malingering and factitious disorders can be used on a role play basis, wherein the JR or UG can be taught how to elicit these things.
Yeah, it's good in
So it's like
just
not only
letting them to-
depression, even malingering and factitious disorders can be trained.
Yeah, that's an interesting thing. Because of the paucity of time, we'll just stop at this. We can discuss it over lunch because the panels will be available. So thank you for providing your insights. Yes, Sandeep. So definitely so. So that's one thing that we need to just to think of. Thank you, sir. Thank you for that idea there. So we'll end up with giving away the prize for the best question here. So maybe Dr. Poonam, you said, right? It's from KVJ Surya. So that as per the panelists as well, so that's an interesting question. Though there is no definitive answer for that, but question-wise, that's the best question.
Thank you, sir. I kindly request Dr. Guru Raj to felicitate the speakers and moderator. Dr. Vinay HR. Dr. Ramkumar GS. Dr. Virupaksha HS. Dr. Adnan Kadiani, Dr. Ajay Kumar, Dr. Harshit Hemant Salian, Dr. Snehil Gupta, Dr. Survi Patra. Group photo. Now we'll have a lunch break. It is at the same place. It is served at the same place, that is the rooftop where breakfast was served. We'll take a half an hour break and please come. 25 minutes break and please gather here again for the next sessions.